Good evening, good afternoon, good morning, everybody. My name is Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure to welcome you to this new journal club by the International Academy for Clinical Hematology. It is 6 p.m. in Paris, 6 p.m. in Nantes, but also 7 p.m. in Athens, 5 p.m. in London. And the article, the paper that was selected for discussion today is a recent paper published in the JCO with the lead author, Professor Dimopoulos from Athens. Thank you, Tanos, for joining us.
Thank you for the invitation.
And the other panelist expert who is not an author or co-author of this paper, as it is usually the case, is Professor Jean-Luc Harousseau from the University of Nantes. Good evening, Jean-Luc.
Good evening. Thank you for the invitation and pleasure to discuss with Tanos Dimopoulos.
Okay, so thank you very much to both of you for dedicating some time to the ICH activity. So this is the title of the paper, Overall Survival with Daratumumab, Lenalidomide, and Dexamethasone in previously treated multiple myeloma. This is the POLLUX randomized open-label phase 3 trial. I don't think I need to spend a lot of time to remind all of you about the design of the POLLUX trial. This has been a very important trial in combination with the CASTOR trial. And the POLLUX trial actually randomized in the relapse setting the use of daratumumab plus lenalidomide dexamethasone compared to the so-called standard of care several years ago, namely lenalidomide dexamethasone. And the initial results of this POLLUX trial, similar, by the way, to the CASTOR trial, were very impressive in terms of PFS. But obviously, the big question is about whether there is an overall survival advantage. And we know in general that in multiple myeloma, it is becoming more and more difficult to see or to generate these overall survival data because of the need for long follow-up, but also because of the availability of many treatment options. And interestingly, in this long-term follow-up of this trial, actually, there was an overall survival advantage for the Dara-Lendex combination compared to Lendex. And this is really important finding, in my opinion. You can see the shape of these curves. We're talking here about the relapse setting, and still you can achieve around 50% OS at 84 months. And even more, if you look to the PFS2, which actually reflects the capacity of salvaging these patients at time of relapse, actually the PFS2 is also in favor of the Dara-Lendex arm. Last but not least, and this is really very impressive again, is about the value of MRD negativity in this trial, because those patients who are able to achieve MRD negativity at a given time point, irrespective of the treatment arm, are really going to enjoy a very nice overall survival, more than 60 or 65% actually at 84 months. So I'll stop here my summary, and I'd like to welcome my two experts for tonight. And as it is always the case in the journal club, the first question goes to the non-co-author, to the panelist here, Jean-Luc Harousseau. And just to get your general thoughts and feelings when you saw this paper being published in JCO, Jean-Luc.
Well, you know that it's not a new trial. The first publication on the POLLUX trial was in 2016 by Dimopoulos in the New England Journal of Medicine. And we've heard so many times of the POLLUX trial in meetings. We have shown so many publication and updated publication. So we know the POLLUX trial. I want to say, before giving you my advice on this paper, that the POLLUX trial was very important, because in combination to the CASTOR trial with Dara, Velc, and Dex, it led to the approval of Daratumumab in relapsed multiple myeloma. More than that, more importantly, when looking at all the randomized trials which were published at that time, comparing a triple combination with a new agent compared to a standard of care with two agents, the two trials with Daratumumab yielded the best results. Cross-trial comparison are of course not recommended, but the hazard ratio of these two trials was much better than all other randomized trials. That is the reason why Daratumumab was very rapidly put in frontline treatment, and we will discuss later the role of Daratumumab frontline. So this trial was very important. So my feeling regarding this paper is that the only important new information is based on updated analysis, significant overall survival benefit, which is obviously very important. We know that it's very difficult to wait enough time to have overall survival data. So usually the primary objective of randomized trial is PFS, but overall survival is very important. To finish, I have to mitigate my optimism because you remember that in this particular trial, patients who were refractory to lenalidomide were not included. And if I remember correctly, 16 patients were lenalidomide exposed, but they had not a very good overall survival. This is one of the situations in which the overall survival is not improved. That means that this combination is just for patients who are lenalidomide naive, which is currently impossible. Lenalidomide is used upfront in all situations in elderly patients with either Revdex or VRD, and we will discuss Dara, Revdex, or Dara, VMP after that. But even without Dara, the standard of care in elderly patients was lenalidomide. And in younger patients, you can use VRD for induction, and you always use lenalidomide maintenance. So this situation where we treat lenalidomide naive patient at relapse is no longer possible.
No, thank you very much, Jean-Luc. And these are obviously very important and relevant points that we will discuss more in detail. So Thanos, my question for you, as highlighted by Jean-Luc, is that you did a great job, and congratulations with this paper published in the New England Journal of Medicine. It was practice changing. It allowed Daratumumab as a combination after the initial approval as single agent to be approved. So what was the point here about generating these OS and long-term outcome data, and what is the implication for practice, for routine practice?
Yes, as Jean-Luc mentioned, there was a series of trials that included calfizomib, elotuzumab, ixazomib, daratumumab, and in all of those there was an improvement in PFS, but in the POLLUX trial, this was the most remarkable improvement. And this explains why In the other trials, let's say in the ASPIRE trials, we still had a survival benefit of 7 months, but here the survival advantage is 20 months. So it means that the most pronounced PFS advantage led to a more marked improvement of overall survival. And this also occurred despite the fact that almost 1/2 of the patients randomized to lenalidomide dexamethasone subsequently received either single-agent daratumumab or daratumumab-based combinations. Despite the fact that, as Jean-Luc mentioned, today DARA-RD may not be used regularly in the relapse setting because of using lenalidomide maintenance or continuous treatment and even daratumumab in the frontline setting, it is always important to have long-term follow-up of randomized clinical trials to make sure that there are not excessive toxicities, you don't see any unexpected late side effects, and also it can provide important information not only for this particular trial, but also overall for myeloma patients. And one of these observations is that the most pronounced overall survival advantage occurred in patients who had received only one prior line of therapy, indicating that it is wise and what all of us recommend, but it has been also reinforced here that we should use our best regimen as early as possible. And of course, the other observation that we'll discuss later is that this is one of the first trials that provided robust data on the role of achieving minimal residual disease negativity in the relapse setting.
No, thank you, Thanos. So my role as a moderator is to be a little bit provocative. So I have here 2 questions to Jean-Luc and to you also, Thanos, to comment. It's about the fact that although we're very happy with this result today, and this is in line, there is a correlation between OS and PFS, and apparently also MRD. Will come back to this. Not all trials recently could show this straightforward correlation. Here it's a good news. And the other point I would like to raise with you is about the salvage treatment options. Because if you want to show an overall survival advantage, you can, I would say, deny or forbid some good salvage treatment to your control arm, and then you can see an overall survival advantage. And here, I think in this trial, half of the patient only received daratumumab as salvage. So what are your thoughts about these 2 points, the correlation between PFS OS, but also the salvage option that needs to be used?
Well, maybe I can start by going back to the general question of the interest of publishing overall survival data. I think it's very important for many reasons. The first, which was nicely explained by Thanos, is that we must know whether a given treatment or a given combination induce or not late complications. So the updated analysis giving the overall survival is very important. But there are other reasons. First, the general reason is that the objective of cancer treatment remains overall survival. So we need to know this data. But maybe more importantly, we are obliged to choose progression-free survival as a primary endpoint, as I said, because it would lead to considerable delay if overall survival was chosen as the primary objective, and the number of patients to be recruited would be very high to show a significant difference. So the trial would be too expensive. But nevertheless, we are not sure that the PFS advantage translates always in an overall survival advantage. There is a nice example in multiple myeloma, which is the Bellini trial, in which the PFS advantage was not confirmed by an overall survival with venetoclax because of excessive mortality in the experimental arm. It's always important to confirm that the PFS advantage translates into a significant overall survival benefit. My personal opinion is that when we have so big differences in terms of progression-free survival between two treatments, if there is no major safety concern, we will find an overall survival advantage. In other words, the hazard ratio of the PFS in the POLLUX trial was in the range of 0.3, which is really fantastic. So we could think that at the end we will see an overall survival benefit. And there is a last reason, which is sequencing of treatments. If you have a better treatment upfront, but if the patient cannot receive the same combination at relapse, on the other hand, the control arm, when the patient relapses, they can receive the experimental arm. As you said, in this trial, patient in the Rev-Dex arm, the control arm, could receive Daratumumab at relapse. Although some of them receive monotherapy, which is less good than the combination, I think that they could have been salvaged by the Daratumumab second line. So it's very important, and especially when using this very expensive agent, to know whether it's more interesting to give the new agent upfront or to give it at relapse, trying to salvage the patient. So yeah, that's the reason why, and I finish here, that's the reason why overall survival data are very important. If you don't want to wait so long, you can use, as in this paper, progression-free survival 2. The time from randomization to progression on the following line of treatment after the first relapse, which gives first the image of the PFS benefits and an image of the possibility of treating patient at relapse. PFS2 is very important, and in this particular paper, it showed a significant and very significant difference in favor of Dara Rev-Dex compared to Rev-Dex.
A good PFS2 means we're not inducing resistant clones and we can salvage these patients.
Yeah, absolutely.
Really good news. Thanos.
Yes, I think that I agree with Jean-Luc that the tremendous PFS advantage that we saw with the first analysis explained the survival advantage, but also I would like to make a comment here that among the patients who were randomized to receive RD, actually 74% of them received subsequent therapies. And not only almost one half received DARA-based therapies, but also many patients received modern treatments at that time, pomalidomide-based regimens, calfizomib-based regimens, autologous transplants. So I believe that this was not a trial that the survival advantage was explained by the lack of subsequent therapies, but rather by the very profound improvement of PFS in the frontline setting. And also because Jean-Luc brought up the question whether there is a role for DARA-RD in the salvage second line in the current landscape of myeloma, we have to keep in mind that still, there are many patients who receive lenalidomide maintenance, but then they discontinue lenalidomide, either because of some kind of side effect or because the patients have been fed up to receive lenalidomide for years, or physician decided that the patient had received enough treatment. So I believe that for the patient who has been lenalidomide free for a long period of time, DARA-RD second line therapy could be a viable option.
So here, Jean-Luc, I think Thanos is alluding to this concept of what we call the lenalidomide exposed but not resistant patient. Do you agree that these patients can be challenged with this kind of combination?
I do agree with Thanos that the patients who progress while receiving lenalidomide maintenance are not the same as the patient who progressed after having stopped lenalidomide maintenance for months or even years.
Yes.
So yes, probably the patients who have stopped lenalidomide can still respond to rescue with, for instance, Daratumumab Lendex. That is always the same question of the duration of maintenance therapy. And you know that the current opinion is that maintenance therapy should be continued until progression. I've been always very cautious with this statement, and I still that the other possibility of giving a fixed duration of 2 to 3 years lenalidomide maintenance gives the possibility of using again lenalidomide at the time of relapse when the patient have stopped treatment.
Excellent, thank you very much. That brings me to another question from the audience, Thanos, because you alluded to the fact to have a sort of fixed duration of lenalidomide. So here the question is regarding this POLLUX schedule. Do you anticipate, or based on your experience from this trial, that there is a minimum duration of treatment which would allow to secure such overall survival advantage, or it's just about the continuous treatment?
Yes, while I agree with Jean-Luc that in the frontline setting with lenalidomide maintenance, there are data even from UK that indicate that approximately 3 to 4 years may be the optimal duration of lenalidomide treatment. And now we also have MRD that may help us to guide the duration of MRD of lenalidomide maintenance. In the salvage setting, I think most of us agree that if the patient tolerates the treatment, it should continue until progression. Of course, even in this trial, and because we had a large number of patients in this trial, there have been patients who have stopped therapy after 5 or 6 years because they say, I am MRD negative, I am fed up, I don't want to continue. But this is the exception. I believe that in the relapse setting, unless there is a toxicity that affects the quality of life of the patient, treatment should be continued until relapse.
Jean-Luc, any thoughts on this issue of treatment duration in the relapse setting?
I do agree with Thanos that usually the duration until the next relapse, but probably the things will change very rapidly because lenalidomide will be probably combined with other agents in order to further improve the progression-free survival during the maintenance treatment. And then if you combine, for instance, lenalidomide plus daratumumab or lenalidomide plus new immune therapy like bispecific antibody, the question of the duration will become very important for 2 reasons. The first is the cost, and I'm discussing of maintenance and not discussing of the duration of relapse. First, the cost, and second, the side effects, especially the infection. Could be the same for the duration of relapse treatment. The duration is becoming a very important question for these 2 reasons: cost and side effects after 1 to 2 years. Lenalidomide is very well tolerated, although patients sometimes are fed up. But if you have a double combination with lenalidomide daratumumab in maintenance, or if you have a combination for relapse setting, the duration will be certainly again a question.
So with this in mind, Thanos, and given it looks like there is an agreement about the value of these results, and they are very strong and impactful. However, one question is about the high-risk cytogenetic patient, because we do not have a proteasome inhibitor in this combination. And where do you see this combination, or in the high-risk population, or is this old dogma of adding a proteasome inhibitor still valid, even with such overall survival difference?
Right. No, I believe that the best approach for patients with high-risk cytogenetics is to combine a proteasome inhibitor and an IMiD, and preferably the more advanced generation of these drugs, and to add on this whatever newer regimen, whatever new agent such as Daratumumab. I believe that, I mean, as we saw here, yet I don't think that we have yet seen a regimen that abrogates completely the negative impact of high-risk cytogenetics. And definitely this is a subset of patients, either in the frontline setting or in the relapse setting, that we need to work more, and to add as many agents as the patient can tolerate, and to have the concept of continuous therapy rather than de-escalating the therapy as long as the patient tolerates it.
Okay, thank you very much, Thanos. Let me move now to something both of you have already mentioned, and we have a few questions about this, is about MRD. And we usually now more and more advocate for MRD, especially in the frontline setting, and our idea is about cure. However, when I look to the survival curve of the MRD negative patient in this trial, actually these curves are even better than what you can achieve in some frontline trials. So my question to both of you is, what is the value of MRD in the relapse setting, and how would you use it in the relapse setting? Although I know it's highly controversial, but still, I think people are asking about it.
Okay, if I can start, I would like to remind to us the curve that you showed, which indicates that essentially the survival advantage in this trial was driven by the much higher number of patients who achieved MRD negativity with DARRD. I mean, you can see that for patients who were MRD positive, it didn't make a difference in the survival whether they had received Daratumumab or not. So in my mind, if you have an agent or a combination that can increase your MRD negativity, then this explains the overall survival advantage. And as you mentioned before, even the few patients that achieved MRD negativity with RD had the same outcome but of the patients with DARRD. But to me, the lower part of the curve is important. I mean, you can see here that if you are MRD positive, it doesn't matter. Daratumumab did not offer you a real survival advantage.
So here, same question to you, Jean-Luc. What is your take on this? Because here,
Mohammed, can you show us again the curves?
Of course.
Because the results of for patients who are MRD negative at the level of 10 to the -5 is absolutely fantastic. You have here 70% who remain free of progression and death, of course, at more than 70 months in the relapse setting. Of course, majority, 50% were in first relapse. But again, it's time for me to confirm what Thanos already said. Especially in first relapse, the objective should be to have the best result possible. And when I say the best result possible, it's to achieve MRD negativity in order to have such a prolonged progression-free survival. A second comment I'd like to make is that 2 years ago, we had a paper by Hervé Avelloiseau on the same POLLUX and Castor trial showing the interest of sustained MRD negativity. My point is that until now, although we have many examples of the relationship between MRD negativity and progression-free survival and even overall survival, the authorities, and especially the FDA and the EMA, still do not accept MRD negativity as a surrogate for overall survival. So I think that for different reasons, I don't want to go into detail, but currently they do not accept MRD negativity as a surrogate for overall survival and even for progression-free survival. So I think that in the near future, we should work in the frontline setting, but also in the relapse setting, at pushing the MRD, the sustained MRD negativity, let's say 1 year MRD negativity, as an objective of new clinical trials, a primary objective in addition to PFS and maybe more than PFS. Not only MRD achievement, but also MRD sustain, at least 6 months, if possible, 1 year.
So here, and by the way, I do apologize because we had a question from a caregiver of a patient about a specific case, but we do not deal with specific patient cases, but I'm sure you can write to us later. We have a question here for you, Thanos, about the use of MRD. Is based on this curve. Well, first of all, would you use MRD negativity finally to decide to stop the treatment? And on the other hand, those patients receiving Daratumumab, if they remain MRD positive, in line with Jean-Luc cost issue, is it worth it to continue hammering them and paying for Daratumumab in this setting? So both ways.
Yes. Okay, yeah. I mean, these are very important questions. I don't know that anybody has the appropriate answer because the trials that will address those questions have not been performed or have not been analyzed. Ideally, one would, I mean, to answer this question, would like to have a frontline population treated homogeneously, induction, high dose therapy, consolidation, whatever, and then a large number of patients should be randomized, MRD positive, continue, stop, MRD negative, continue, stop. So this is an impossible trial to perform. However, we can get some information indirectly. So I believe that, as Jean-Luc mentioned, in patients who are sustained MRD negative, and when I say MRD negative, I also add PET-CT negative because we have to evaluate the bones as well. For several months, for several years, one may feel more compelled to discontinue maintenance therapy, especially if the patient does not belong to a high-risk myeloma. So if I have a patient with standard risk myeloma who has received 3 years of lenalidomide maintenance and who has achieved MRD negativity by both flow, by bone marrow assessment and PET-CT, let's say on 3 or 4 consecutive measurements, I would be able to discuss with the patient whether we continue or not. On the other hand, it is impossible to know whether, if you have a patient who remains MRD positive, whether the treatment that you give prevents a real relapse. So nobody knows. I mean, in this patient, I would not feel at ease to stop therapy, because one may say that the treatment has achieved resistance at a very low level. Somebody else may say that this treatment keeps the tumor load at a very low level.
Jean-Luc, what are your thoughts about the use of MRD in the relapse setting to guide the treatment?
Well, if you look at this curves with PFS so brilliant in patients with MRD negativity, one can ask the question, did these patients who are at 5, 6, or 7 years still free of progression, did they continue the treatment? Probably they did stop the treatment even without the control of MRD negativity. But in addition, if you have 1 year MRD negativity, yes, probably we could at least address the question. And I agree with Thanos that it is very difficult to set up a clinical trial able to demonstrate the benefit of stopping or continuing the treatment in the setting of patients with prolonged MRD negativity. But at least that it would be ethical after discussion of with the patient to stop the treatment in a patient who has a very low tumor load, negative MRD, negative PET scan, and see what happens. It could be possible. Of course, you know that I'm interested in the cost of drugs, and one of the reasons would be the cost, but also to save the possibility to reduce the treatment at the time of relapse. So yes, I would be interested in, after discussion with the patient, to stop the treatment if MRD negativity is prolonged, and it's mostly, of course, for first relapse patients.
Thank you, Jean-Luc. So we have a couple of other questions we won't be able to take. One question is about whether isatuximab can replace daratumumab. Well, obviously, isatuximab hasn't been approved in combination with lenalidomide, but it has been approved with pomalidomide. So my best guess is yes, but this is my personal opinion. And then we have another big question about the new tools for assessing response, especially mass spec, and we will dedicate a special session after EHA for this topic. So we're reaching the end of this broadcast, and the tradition is to give the last word for you, Thanos, as first author. What would be your concluding comment?
Well, I think, first of all, it is important to have a long-term follow-up of studies and to collect data as it was done here for subsequent therapies, because this can give you important information. It is important to strive to see whether a regimen can give you an overall survival advantage, even if it is becoming this more and more difficult. And also, it is important to record long-term side effects that may occur many years later. For example, we know that the most problematic use of long-term lenalidomide maintenance is diarrhea. So this, we realize only after we start moving lenalidomide up front and using it for several years. However, I believe that the myeloma treatments are so effective, and in many patients, myeloma is becoming a chronic disease. And I could not agree more with Jean-Luc that we should all try to persuade regulatory authorities that MRD is a robust endpoint that could be used for a more rapid approval of regimens, especially when we are interested in the frontline setting and improve the frontline regimens.
Thank you very much, Thanos, for these words of wisdom. Thank you very much, Jean-Luc, for being a panelist on this fantastic work, and congratulations to Dr. Dimopoulos and all of his co-authors and all the contributors to this large international trial, including, of course, families and patients who, of course, has put a lot of energy and dedication, and we are very grateful. Thank you all for attending this ICH Journal Club.
Thank you, Mohammed, for the invitation and for the opportunity to interact with you and with Jean-Luc on this topic.
It's always a great honor and pleasure, Thanos, and you're always welcome at the ICH, and we will connect, I'm sure, very soon at ASCO and EHA, because we will have a lot of activities. But in the meantime, wherever you are, please stay safe and keep well. Take care.
Thank you.